Hi, good afternoon, and welcome to the first webinar from Muscat Endoscopy Academy. My name is Dr. Samer Al-Duri. I'm a senior consultant in gastroenterology from the Medical City Hospital for Military and University and Military and Security Services in Muscat, Oman. And it's my pleasure today to welcome my good friend, Dr. Zlatan Mujagić, who's a senior consultant in gastroenterology from Maastricht University Hospital Medical Center in the Netherlands. And the topic that we'll be discussing today is the role of endoscopy in functional bowel disorders. So I'm going to give the floor to Dr. Zlatan to present himself, and then we will get rolling. Please, Dr. Zlatan.
Thank you very much, Samir, for inviting me here. Happy to be here. Indeed, just to introduce myself very shortly. I'm a gastroenterologist here in Maastricht in the Netherlands, specialized in a combination of IBD, so inflammatory bowel disease, and neurogastroenterology and motility. And specifically also the overlap between inflammatory and sensitivity disorders of the gut. I did my PhD in irritable bowel syndrome quite some years ago, and I'm still quite active in research as well, both on the topic of, as we can now call them, disorders of the gut-brain interaction, so functional GI disorders, as well as inflammatory bowel disease. And happy to talk to you about endoscopy in these patients as well. Yeah.
Just to start here, like we've both been doing this for a while now, and one thing that we notice quite regularly that we get a huge number of referrals, whether it's from GPs or from other clinics in the hospital, for patients that are suffering from different types of symptoms that can be related to functional bowel disorders. So, if you were to shortly triage those functional referrals, who to scope, whom not to scope, and whom to consider for a scope.
Yeah, I think it's a very important topic in general because, we do a lot of endoscopies in daily practice, and that's what we are trained to do. On the other hand, those are costly procedures. They are invasive. We know that in many countries, the waiting times can be massive, sometimes for months, for people waiting for endoscopy. And it's quite important then to use those resources in a good way and to do the endoscopy in patients who we expect actually have a high chance that we will find specific pathologies during our endoscopy and do something about it. You see also when you look into the literature that a lot of endoscopies are done in patients without alarm symptoms, without a good medical indication, from which you actually know that the chances that we will find something relevant during endoscopy are very, very low. So in most cases, just an endoscopy to reassure the patient, but also to reassure the doctor that there's nothing organically wrong in that case. And that's mostly not a good indication. Like I said, it's costly, but it's also invasive, of course, specifically when we talk about colonoscopies, but also upper GI endoscopies. They can also sometimes lead to complications. And, it's not a very good thing if we cause a complication in a patient for which the initial indication wasn't very good. They are quite good. The triage can be done quite well, actually, because we know from literature, when you specifically look at upper GI endoscopies, in some countries, over 60-70% of upper GI endoscopies are done without a good medical indication. So in young patients who don't have any alarm symptoms. If you think about alarm symptoms for upper GI endoscopy, you should I think, separate the lower GI and upper GI. If you think about upper GI, alarm symptoms are older age, and that depends a bit on the region. So in Europe and North America, it should be above 60. Although the Americans are quite conservative, so they put the age on 40 to 50. But in Africa and Asia, it should be above 40 because of higher chances of gastric cancer in a bit earlier age. But if you don't have any alarm symptoms such as anemia, dysphagia, weight loss, then an upper GI endoscopy shouldn't be done just for dyspepsia, because functional dyspepsia is very common. 10 to 20% of the general population has functional dyspepsia, and that's not a very good indication for an upper GI endoscopy. And even if you think about, organic causes such as peptic ulcers or esophagitis, most of these things can be treated with a PPI. So, if you do the endoscopy, you find an ulcer which causes dyspepsia, you give the patients proton pump inhibitors, and 6 weeks later they're better. You can also just give them proton pump inhibitors because that's also the same treatment for functional dyspepsia in the first place, and then reassess after 6 weeks. And when in doubt, you can do the endoscopy again later on, and if the patient is better, you have treated the ulcer, peptic ulcer, and that's it. So there's no need for the endoscopy in the first place because you don't. Well, it will not change your therapeutic approach afterwards.
Many of the referrals that I see, you get like a patient where they say, okay, patient with dyspepsia, they received, they've done like the H. pylori antigen test and it was positive and they were eradicated, and then they retested them and they retested negative, but the patient is still suffering from similar symptoms. And what we know from some of the studies that the number needed like to treat in order to get rid of the symptoms is like only 1 out of 14 patients, I think, that get rid of the dyspeptic symptoms when they are actually eradicated from H. pylori. So, and they end up in that like functional dyspepsia bucket quite instantly sometimes. But how do you look at these referrals? How do you counsel them? What do you do if you were to give like in 60 seconds, let's say, like you look at those referrals and you want to educate our colleagues on what to do with such referrals? Like, there's persistent dyspepsia and there's no H. pylori, and there are no other alarm symptoms, as you said. There's no dysphagia, there's no weight loss, there's no melena, no hematemesis, nothing else. And the patient is under 60 years of age. What do you do in these cases? And when would you consider doing something else, such as like, a pH monitor or manometry and so on?
Yeah, well, excellent question. There's actually a randomized controlled trial done by the group in Nijmegen here in the Netherlands. They've published it a few years ago in the JAMA on patients who were already referred by the general practitioner for upper GI endoscopy because of functional dyspepsia, and they selected those patients who didn't have any alarm symptoms, so actually with a bad referral, and they randomized them into online education about functional dyspepsia, just telling them what it is, that it's quite common, that an upper GI endoscopy doesn't rule out anything else, and also doesn't lead to change in therapy plan in most cases, and that actually upper GI endoscopy is not very useful to do in functional dyspepsia. So just short online education, which was sent to these patients, and the other ones didn't get online education, and both of them were afterwards seen prior to the upper GI endoscopy by a nurse, just to tell them about the procedure and what to do about it. And also these nurses also trained, to ask the people, is it really something that you want to do because you don't have any alarm symptoms? And interestingly enough, that the ones who are educated online, just about knowing that's what is functional dyspepsia, so what they actually have, and what the role of endoscopy or the unuseful role of endoscopy is, led to enormous decrease in endoscopy. So just patients themselves said, I don't need this endoscopy because I don't think this is the right procedure for me. And I don't know the numbers by heart, but I think actually it's something about 80% of decrease in the intervention group compared to just a small percentage in the non-intervention group. So what actually is needed is, quite often you probably recognize it. We often have just a little bit of time when we see these patients, they explain their symptoms, and it's much easier to say, we'll do a checkup, you get an ultrasound and a upper GI endoscopy, I see you afterwards, and then, if nothing's wrong, I'll tell you nothing's wrong, you can go home. And explaining them about functional dyspepsia and about the need or the not need for further investigation takes a bit more time. But you should invest like 10-15 minutes explaining to them what it is, that they don't have any alarm symptoms, that further investigation doesn't lead to new ideas about the treatment plan in that specific patient, and then focus on the symptoms, the triggers, and what you can do about it. Because, well, most cases, reassurance is more than enough for these patients, and reassurance doesn't mean an endoscopy, because patients are mostly not reassured about after endoscopy, because they come back, that's negative. Well, then they have next question: could I have a CT scan or MRI scan, or should you refer me to a different doctor? So take your time, 10 minutes, and explain them what functional dyspepsia is, what alarm symptoms are, and how it can be treated. Yeah.
You're totally, absolutely right. I agree. The issue is like sometimes time. In
Yeah.
order to take the time to explain to these patients, and like, use a pen and paper and like, just to draw what this is about, and like, disorders gut brain interaction, and quite often you have to like kind of focus on the terminology that you're using, because you don't want to make them feel like that it's psychological just in their heads.
Hmm.
So I feel that quite often, because this leads then to the next question, is like, if we're going to treat it somehow, if it's like, let's say, dietary change restrictions, or like some sort of dietary modification, let's say lifestyle modification would not help, then you end up like uh in the next stage where you may need to use some like, antidepressants or something like that, like, and in those cases, it's very important that the patient does not feel that we are undermining their symptoms.
Yeah.
And I
Yeah.
think when we are so short on time, it's usually becomes quite difficult, and the easier way out becomes like, okay, let's just do the gastroscopy and see. um, so I totally understand. I totally agree with you. But what about if a patient like this is the same scenario, but the patient is above 60 years of
Yeah.
age? Would you then scope that patient
Yeah, well, in
or
that case,
no?
if the symptom onset is at an older age, and like I said, it depends a bit on your geographical region, so on the ethnicity of the patient, because in some regions, specifically gastric cancer is more common in specific regions. Yeah, and older age, you should be less restrictive with upper GI endoscopy. So in that case, I would. Even then, if you look at the numbers, of course, the prevalence of gastric cancer is quite low, so your chances of finding something there which is relevant is still low. On the other hand, that's something you don't want to miss. But I mean, if a 20-year-old comes in with a stressful period in the last year, and now a lot of upper GI symptoms without any alarm symptoms, you know in forehand, if you do the endoscopy, nothing will be there. And if you see a bit of erythema or redness, you still will give some PPI and say, well, this is probably something that will help. And if it doesn't help, then you should go to a next step to, indeed, as you indicated, neuromodulators such as tricyclic antidepressants, which can be very effective also in functional dyspepsia. And for lower GI, it's a bit different because, of course, you have irritable bowel syndrome, which is quite prevalent in general, specifically in young people. Also 5 to 10% of general population, depending on the criteria we use. But there, you have a bit different alarm symptoms. Also, older age is important because of colon cancer. So above 50, 55, you should not be too cautious of doing a colonoscopy because of polyps and colorectal cancer. But in younger patients, you should also think about celiac disease and IBD, specifically when diarrhea is present. But in that case, that can be both done without an invasive procedure. So celiac disease can be tested by serology, and a calprotectin, which is low, already shows that probably there's no IBD if there are no alarm symptoms. And nowadays, RBD is also something that can be at least screened for using ultrasound. So that's something that I use quite often nowadays, and don't go that easily to a colonoscopy unless there are alarm symptoms such as bloody stools or weight loss. Yeah.
Issues.
Sorry,
Well,
you're
before moving on to this lower GI issues,
Mhm.
if a patient, let's say, like we quite often talk about, optimizing their PPI therapy. Like we're talking about patients that have dyspepsia, and we're optimizing their PPI therapy. What does that mean in practice?
Well, you see quite often the patients don't use it, according to guidelines. So I tell my patient to use it in the morning on an empty stomach. And what I mostly do, if you're already, giving PPI on trial, do it well. So I give them for 2 weeks, 2 times a day, 40 milligrams of PPI, so 80 milligrams a day for 2 weeks, and then afterwards for 4 weeks. 40 milligrams a day. There's no strict guideline on how you should prescribe it, but that's what I do in general. And then you have a good dose for 6 weeks. If there was an ulcer, if there was a gastritis, which is peptic, that should be treated in these 6 weeks. And if it's acids, then that should be treated in these 6 weeks. And after 6 weeks, you can reevaluate and see where you are with the patient. And even then, if there are no alarm symptoms, H. pylori, as you indicated, should be tested. Quite often, I think that H. pylori is just it's just a coincidence. People have H. pylori. They sometimes develop functional dyspepsia. Whether it's H. pylori related, quite often it's unknown. You then treat it. In some patients, the symptoms go away. Then it's probably H. pylori related. In other patients, the symptoms don't go away, and you should go for a next step, which can be, gut-directed hypnotherapy. Sending a patient to a dietitian or maybe a neuromodulator.
Yeah.
But good explanation about the symptoms and also about your steps in the future are quite important, so the patient knows this is something we'll start now. If it doesn't work, you have a plan B and a plan C, and a gastroscopy should only be done then if in doubt or if alarm symptoms pop up. Yeah.
And in terms of dosage, do you shuffle PPIs? And in terms of dosage, is it 20 BID, 40 BID? Do you switch around? We know they're not totally equivalent in doses.
Yeah.
So what is your practice usually? Well, my practice, I shuffle them around, and I go for maximum suppression, just in case the patient is not compliant, at least giving them as much as they would be taken. It's just a pragmatic approach that I have used, which works in some cases, in other cases doesn't work. But what does the evidence say about this part? Do we shuffle them around? Do we switch?
No, they're not very good studies. So mostly just expert opinion and what experts do. But of course, if you look at the pharmacokinetics, we know that the proton pump inhibition is not the same for all PPIs. So you have the stronger ones and the less strong ones. I mostly use pantoprazole or esomeprazole as a PPI, and sometimes I do shuffle them around. But the reason to do is, if you start on pantoprazole and it doesn't have any effect in 6 weeks, I don't try a second one because, it didn't have any effect. If patients say, no, I did feel better, it wasn't optimal, and indeed, you should always check for compliance, because, as we know, quite often medication is not taken, not only PPIs, but anything. So double check that always. But if you think the patient was compliant, it is effective, but not fully, you can all continue in a higher dose or maybe switch to a different PPI as a trial and error, but it stays trial and error, so there's no evidence to guide your decision there.
Okay, and what would you move on to doing, a patient that still has reflux symptoms despite all of this? When would you move on to doing the functional tests?
Well, there are two main reasons. The first one is if you think that, but then in that case, you probably have already done a gastroscopy. So if you have really an esophagitis, specifically the more severe ones, the LA classification guides you there. But if you have more severe esophagitis and you give someone PPI, you do upper GI endoscopy again to test the effect of your treatment. And if under PPI they still have an esophagitis, that's a perfect reason to do a pH testing to see, so pH impedance, to see what's going on. And that can be a step towards surgery. So if you're thinking about this patient doesn't respond properly to PPI, then you can go to surgery. And in patients who don't have an esophagitis but still experience a lot of symptoms, it can also help to distinguish between, gas reflux, which can also lead to reflux because it's a combination of gas and then also acid. That can be treated by logopedia, because you can quite often just pressure in the that patients build up in the diaphragm and also pressure on the stomach, and logopedia can help actually to reduce that pressure in the.
What does that mean? What does that mean for a standard gastroenterology? Well, what does it mean, like logopedia?
Well, what they actually teach the patient in that case, quite often it's what patients do due to a trigger in their guts, in their stomach. They increase the pressure on the diaphragm. So the same thing, I explain my patient the same thing. If you're stressed, you increase the pressure in your neck and you feel tense. You can do the same thing in your stomach. That's probably also the reason why quite a lot of patients have bloating. Because diaphragm, if it contracts, it presses down, which is a biologically logical reaction, because it gives your lungs more space. If you're stressed, that's what happens. Your lung get more space. So in case you see a predator in a wood, then you can run away because your lung have space.
Yeah.
On the other hand, if that stress or the trigger comes from inside, the same thing happens. Your lung gets more space, but your abdominal organs get less space, and you get bloated. So that's probably the reason why a lot of IBS patients experience bloating, and that's also an explanation why many patients can tell you sometimes that bloating or the visual distension, I feel pregnant, comes up in seconds, and that's not gas, because if it's gas, then you need production of gas by the bacteria. It slowly develops. If it develops so fastly, then it's not gas and it's just pressure that builds up due to the diaphragm. And logopedists also treat people who singers, and they learn how to relax the diaphragm. So diaphragmal breathing can help there. So singers can do that, and that's something that I can't, but a logopedist can also teach your patient to relax the diaphragm. In that case, bloating can go away. So that's one thing. And the other thing is that if they have a lot of burping or rumination, so food comes back into the mouth, so not vomiting, but just a sensation of food coming back into your mouth, that's something that can be very helpful for these symptoms to reduce them. And also in case of reflux, which is combined with gas, that's something that can be quite effective. Yeah.
Fantastic. That's something that you have available only in bigger hospitals, right? I mean, because as far as I know,
probably you need, because most logopedists are just specialized in speech. And in swallowing, so more the upper part of the esophagus, and so you need logopedists who are specialized also in diaphragmal breathing. It's quite easy actually for them. I know it's not that difficult, and there are also YouTube instructions on how to do it. So I don't know which one to advise, but if you Google it, you can also find it online for your patients to that. But if you have a logopedist who is specialized, that's of course preferable.
Yeah, and my last questions on the upper GI stuff before we move on to the lower GI stuff is, there are some medications that may mimic organic disease that may give that kind of those dyspeptic symptoms, or this discomfort and everything. Are there some usual suspects that we should always check for if a patient presents? Of course, this all has to do with taking good history and so on, but would you be thinking about maybe 2 or 3 medications that are always in the back of your head that you would ask any patient right away if they're on them to start asking more, or does that something that is usually not?
The thing is with medication and the GI system, many can have effects on the GI system, both and also paradoxically sometimes. So the same, tricyclic antidepressant that you give to treat functional dyspepsia, sometimes patients develop GI symptoms because of them. And the reasons for specifically tricyclic antidepressants, because they're quite. I also use them to treat diarrhea because they induce constipation. But if patients have normal GI function, they start a TCA because of their depression. They can develop, constipation, and then rather than coming to you with constipation, they come to you with upper GI symptoms because it's all blocked.
Mm.
So it's not specific on which drug, but just double check when did the symptoms arise and did you start any medication before that, or what are you using in general, and it's always smart to check for all the drugs and their side effects that patients use. And also, to add on that, it's quite important to check their medical history because thyroid issues, diabetes, those are actually diseases that quite often also give rise to GI symptoms, and specifically also diabetes and patients who use insulin. We know that hyperglycemia leads to well, temporary gastroparesis because you have high sugar levels.
All right, go ahead.
So specifically about diabetes, so higher glucose levels lead to temporary gastroparesis, and which is actually a biological effect, because you have too much glucose in your blood. So what the body tries to do is keep the food in the stomach as long as possible to reduce the glucose levels, and then let it pass towards the small bowel to be absorbed again. And the other way around. So if your glucose levels are low because of your insulin, then your gastric emptying time increases. So because you need glucose in your small bowel to be absorbed, that can give rise to GI symptoms, upper GI symptoms in this case. So the medical history is quite important when you see these patients. Yeah.
Yeah, and this is like a nice segue into like this lower GI symptoms, I think, because quite often they are kind of interconnected. Where
Yeah.
like the patient comes in and like I remember when we were in med school, I mean everybody was just talking about IBS. I mean function. I don't remember hearing about functional dyspepsia back then, to be honest. And now it's like you have like this kind of big group of interconnected ICD codes or diseases where like the patient describes something and we don't know where to start kind of, but it's easy to kind of fit them in. It's relatively easy to fit them into the box, like the
Yeah.
Rome 4
Yeah.
or whatever it is we're looking at. Uh, but how do you distinguish whether like this patient has IBS and whatever whichever type of IBS we may talk about, and whether it's functional dyspepsia, and how often are they actually like interconnected? How often do patients have both at the same time? And
No.
does that affect their therapy, or it doesn't matter?
Yeah, it's an excellent question actually, because I'm happy with the Rome criteria, in this case Rome 4, specifically for scientific research. If you're going to study these patients, you need a box. You need to understand what you're studying, and if I'm doing a study and you're doing a study, then we need to be able to compare our patient populations. So for those, the Rome 4 criteria are great. For daily clinical practice, they can be useful as well, but much less. So in daily practice, it's even if you look into these boxes, functional dyspepsia, you have two different subtypes. Into IBS, you have four different subtypes, and and within these subtypes, there is no one patient alike. They all have their different medical history, different ages, different triggers. So it's all about taking the time, as we were talking about, and personalization of the treatment. So you have to understand what the symptoms are that are driving the quality of life reduction in these patients. So what are their most bothersome symptoms, and focus on that in your treatment. And also patient education, explaining them what's going on. So it's a disorder of the gut-brain interaction. The nervous system is involved, the gut microbiota, gut function, and there's no miracle pill that I'll give you and in 2 weeks everything is over.
Yeah.
But there's always a holistic approach. Lifestyle, sleep quality, food quality. If psychopathology is present, so not all, but 40% of patients with disorders of gut-brain interaction have an anxiety or a depression. Anxiety disorder or depression. That's quite a lot, 40%. What
That's
other words, 60% are not. So it's quite important to identify that in specific patients. If you send every patient to a psychologist, you will have 60% of the patients who are not happy with you because they don't have any psychological issues. On the other hand, 40% do have. And if you just focus in these 40% on GI symptoms without addressing their anxiety, these GI symptoms won't go away. So it's all about, taking the time, understanding what drives the symptoms in your specific patients, which symptoms are the most important ones. Well, is diarrhea, abdominal pain, or epigastric pain, and focus on that one.
Right, right. Perfect. I totally agree with you on that. And so a patient, let's say you have a patient that presents to you and they have, let's say that like mixed bowel habits or diarrhea, right? And maybe sometimes some bloating, some pain, and so on. Which pre-scope tests are non-negotiable in order for you to actually consider this patient for endoscopy, a colonoscopy in that case?
Yeah. Well, yeah, like I said, so first, alarm symptoms, that's a yes or a no. If there are no alarm symptoms, then I actually don't have really a good reason for endoscopy. What I mostly do then in that case, if diarrhea in any form is present, I do tests for celiac disease, just serology and a calprotectin. If the calprotectin is low and your serology is fine, then you excluded actually inflammation, you excluded celiac disease, and you can continue with the diagnosis of IBS. But also quite important to tell the patients actually on your first consultation that the chance of the diagnosis being IBS is sky high. So I tell them you probably have IBS, you adhere to the criteria, but you also have diarrhea. Let's do a calprotectin test. Let's do celiac serology, just to be sure. But then they already know you're doing that out of precaution, but you're actually expecting IBS. What many colleagues, I think, do in a not optimal way is that you see the patient, you listen to the symptoms and to their story, and then you think, well, it's probably IBSD, but let's do a stool test, a blood test, an ultrasound, and a colonoscopy, and then I'll see them afterwards. You do all these tests, they come back negative, and you expect then, if you say everything is negative, it's IBS, that the patient is happy. But what actually happens is that the patient thinks you did all these tests, so you probably thought something was wrong.
Yeah.
And then you back, everything is okay, and now you have no idea, so you just give them a diagnosis of IBS. So they go, out of your room, and they're not very happy with you, and they go to a different doctor because you have done a lot of tests, you haven't found anything, so you have just given them a diagnosis.
Yeah.
If you have had said that, in the beginning and said it's probably IBS, I'm doing some tests just to be sure, they probably come back negative. That's it. You have a totally different story when you see them back. Then you can say, as expected, this is negative. Let's continue on the IBS path, which we already talked about. Or maybe what I quite often say, this is some literature. Go and read some patient information about IBS. You already know. It's the other way around. If you do a colonoscopy because you think this could be maybe Crohn's disease, and patients come back with an ileitis, and it is Crohn's disease, it's also fine. They won't be mad because you said it's probably IBS. You did the test, you found Crohn's disease. You said, we thought about IBS, but we did colonoscopy just to be sure. Crohn's disease is diagnosed now. We'll continue on that. It's fine. So it will not disturb your patient-doctor relationship in that case. The other way around, it will. So I quite often tell them the diagnosis already before doing any tests. Yeah.
Right. So that kind of gives them heads up before you start. Yeah. What about like this two small elephants in the room that sometimes patients don't know about, but we gastroenterologists sometimes think about, and it's microscopic colitis and bile acid diarrhea. How do we how would you move from thinking only IBS to thinking about them other two diagnoses, and because then you end up in a different, although the treatment might be the same sometimes, but having the diagnosis makes a difference, right? I mean, suspecting microscopic colitis, you're gonna have to do a colonoscopy and the biopsy and so on. The bile acid diarrhea, I mean, not everybody has access to the tests, right?
No, that's
So how do you think about those two diagnoses, and when you have a patient in the room, what is your I mean, tell me your thought process.
Yeah. Well, I think those excellent things to keep in mind. So it's a good question. If you think about, you should split them up because they're two different things, of course. If you think about microscopic colitis, something that we see more in older age and less in younger age in general. And in older age patients, we are more prone to do a colonoscopy anyway, and specifically if it's watery diarrhea. So if patients indicate, I have 8 times a day watery diarrhea, that's something that sounds like microscopic colitis. And then you should also ask specifically to the endoscopist, so put in your referral that you want biopsies regardless of the endoscopic results. Otherwise, you still won't find it.
Right.
In younger patients, you see it less often. On the other hand, if you're talking about microscopic colitis, indeed, the number one treatment goal is reducing diarrhea, just as in IBSD, if the diarrhea is the issue. So your treatment will be the same for a while. The only thing is if the standard treatment like as fibers and loperamide, etc., doesn't work, then you go to the next step, and then you go to immunosuppressants, such as budesonide, and maybe even stronger ones in microscopic colitis. So for that, yeah, I agree. The diagnosis should be made. And it's a difficult one because we don't have very good criteria, to accept watery diarrhea, because there are also probably microscopic colitis patients who have less watery diarrhea and
Right.
who have the diagnosis of IBSD and never had an endoscopy, or had an endoscopy without biopsies, and you still didn't. So we probably missed that diagnosis for like 30, 40 years ago. We had no idea what it was, so we missed
Yeah.
everybody.
Yeah.
So that may change in the future based on new research. Regards to bile acid diarrhea, that's also something interesting. If you look at studies who assessed patients with IBSD, many patients with IBSD respond quite well to bile acid binders, just as cholestyramines. The question is it then bile acid diarrhea as a separate entity, or is bile acid diarrhea sometimes part of IBSD
Right.
and that's more a semantic discussion. I just use it quite often as a potential treatment. So if patients have a lot of diarrhea, I mostly start firstly with fibers. If it doesn't work, I quite often give them also, bile acid binders to see, just to try and error to see what happens. If it works, it's fine. And I quite often do the tests. We have options for tests here for bile acid diarrhea. I rarely do them because actually just a trial on medication is as effective, and the medication doesn't have any side effects.
Mm.
Hardly any side effects. And
Mm.
in many centers, the tests are not available. The a priori chance of bile acid diarrhea is, of course, higher in specific populations. So if you think about, Crohn's disease patients with ileum disease or ileocecal resections, or patients who have had cholecystectomy, those are the patients who have a higher chance of bile acid diarrhea. Yeah.
Mm. Mm. How about overweight patients?
Yeah, as well.
Women, I have noticed usually, even when they do have not undergone cholecystectomy, I've seen it more often than in men. Is that the way it is? It is more common in women?
Actually, I'm not sure about what the literature says about it, but yeah, I have the same feeling indeed. Yeah, yeah.
Yeah. Yeah.
I'm
Okay.
not sure. I haven't looked up literature on that. Yeah.
Yeah. Yeah. Okay. And if we move on to the patients that are constipated, on the other hand, which is a very common thing, is like I get patients where you get like patient with a chronic constipation,
Hmm.
where basically it is not clear what is the price. Is it IBS-C? Is it slow transit constipation? Is it some pelvic floor
Yeah.
dysfunction, dyssynergia, and so on? How do you reconcile, such referrals? Because what you get is like patient that has one bowel motion every second week or once a
Yeah.
week,
Yeah.
and quite often, unless you really dig deep while speaking to the patient, you don't get closer to the diagnosis. How do you think in that sense about that group of patients?
Yeah. From a diagnostic point of view, it's maybe a bit easier because constipation is hardly ever an alarm symptom. So it's mostly functional, and then I'll split it up into groups or three. So indeed, pelvic floor dyssynergia is quite important. quite often it's an overlapping combination, but if you split it up, pelvic floor dyssynergia, slow transit constipation, and indeed none of those, but just IBS-C, you can do the tests for it. Regard to the colon function, it's colonic manometry, but actually what's quite more easy and more easily available is the marker study. There are different protocols to do these marker studies depending on what you have available in your hospital. But for example, in our hospital, we have a marker study where patients take specific markers for 6 days, which is a capsule with plastic markers.
Right.
Every day a marker, and then on day 7 you just make a picture, an X-ray of the stomach, and you follow the markers. And every test has its own formula to see how fast the transit is. So
Right.
you can see whether there's any slow transit there. That's one. And good, actually, for all patients with constipation, you should do good digital examination to see how the pelvic floor is. Because quite often there's pelvic floor dyssynergia, and even in patients who also have slow transit, they quite often have pelvic floor dyssynergia as a compensation mechanism, because patients have constipation, so the stool is hard, and they adapt to these symptoms that they have, which quite often leads to dyssynergia. And if you are doubting yourself whether you're good enough in finding pathology by digital examination, then send the patient to the pelvic floor physiotherapist. If you just send them for a consultation, they say everything is fine. That's one consultation. It's also good, but you can also send them for a diagnostic consultation.
Right.
So a combination of those two. And then, of course, you have a lot of laxatives, and nowadays, happily, also a few new generation laxatives which are very effective, and you can combine them all. And also quite important, some studies are done on that. There were a lot of stories previously that patients who use long-term laxatives that has negative effects on their bowel function. That their colon will become lazy, but actually studies have shown that's not the case. So you can use laxatives indefinitely without any consequences on your bowel function, and you can combine them, and
Right.
just find the right laxative for your patient.
Yeah. A lot of these patients, like in my practice that I've seen, many of these patients end up also in the endoscopy suite, and quite often we do not. And the reason why they end up there is because, as a part of the screening, because they do the fit test and ends up being positive due to
Yeah,
hemorrhoids, right?
yeah, yeah,
And then when they show up and you ask them if they have any other symptoms, and they say no, they don't have anything else, and that's the only thing that you see. Maybe you see some diverticular disease as well, due to the long-term constipation, but like you may find the occasional polyp here or there, but in my experience, most of the time that these patients actually do not have anything that is wrong in their colon, and getting them clean sometimes for clean enough for a colonoscopy can be quite challenging,
yeah,
also, which sometimes risks the fact that we need to bring the patient for a second procedure because it's just not high quality procedure. And if you've started, you cannot say like, oh, but this patient has IBS, we don't need to do it again. If you've done it once and it's not clean enough, then you need to bring the
yeah,
patient again. And this whole it's kind of this domino effect, right?
yeah,
That I think quite often we think about more when we're on the receiving end of the referrals, right?
yeah,
While the quite often our colleagues, maybe they do not know those nuances. So this is the point of this whole discussion, right? To make it to give a clear picture even to our other colleagues, junior gastroenterologists, because quite often and surgeons, because quite often they're the ones that actually make those referrals to
yeah,
endoscopy. It's not
yeah,
just from the GP. I mean, from my experience in Sweden, we have succeeded in teaching our GPs in when to refer. So they've become
yeah,
much better at doing this. But quite often you get them from surgeons or from junior gastroenterologists still in their training. So I think it's very important that you point this out. But my last thing that I want to ask you about is like in terms of therapy for these patients, because many of them they will tell you, oh, I've tried everything, like I've tried the lactulose, I've tried like the Movicol and whatnot, and nothing that's not helping. And there is a bunch of new drugs out there. Is there? I have my own preferences, but what would you select if a patient tells you I'm not responding to Movicol and lactulose? What would you select? And
Well,
what is response? How would you define response?
yeah, that's a very important one. So you have to set treatment goals together with your patient. So if a patient had a bowel movement once a week for his own whole life, and now it's once every 10 days, and it leads to symptoms, you shouldn't go to try to get them to once a day because you never succeed. You should go back to once a week, and that's fine for them. So bowel movement is quite personal from patient to patient. So check what's normal for them or what was normal for them, and try to restore that as much as possible. So setting clear, realistic goals is important. And also, when you quite often they have already used laxatives themselves because they just over-the-counter medication or by GP. But go back with them and check how they used it, how often, how long. Have they taken enough water? If you take Movicolon and in a small glass of water, and you've taken it for 2 weeks, then it wasn't effective, then you haven't done it right. So you have to explain them how it works. Well, and what I quite often do, like I said, I make combinations. So Movicolon is quite effective with a lot of water. Magnesium hydroxide, it can be taken in because it's just a chewing tablet. Uh, I don't often use lactulose because it leads to bloating.
Right,
You can microbiota break it down into gas, and then you have a lot of bloating. So I mostly don't use that,
right,
except for other indications for hepatology. And also senoids, so like bisacodyl can be quite effective as an add-on medication. And then if those don't work in a combination, then I add linaclotide or precalopride nowadays,
right.
which mostly are very effective, but are much more expensive. So it also depends on your medical system and whether they're available or not. Yeah.
Right, right, right. Those
And
are the only
once
two that
again,
we have right now in Europe, right?
yeah,
Prucalopride and linaclotide, because there's a bunch of other ones that are available in the
in the United
in
States as
North
well. Yeah, yeah.
America and Japan.
And the basics, like I said, the basics is pelvic floor function, pelvic floor therapy, and lifestyle in general. So your bowel movement, in general, your bowel function is functioning on a rhythm. So you should have, if you work night shifts, 2 to 3 nights a week, and then 4 days a week you have regular shifts, your bowel movement goes in all directions. So you should have regular bowel movements or a specific regular day. So that's important thing. And also our position on the toilet is quite important, because nowadays the regular way we sit down as we sit on a chair, but it's not biological. So our pelvic floor doesn't open, and specifically our puborectal muscle doesn't open
Right.
fully in that way,
Yeah,
because 10,000 years ago we didn't have a stool to sit on. So
yeah.
we you need you need that position where your angle of your knees is like this.
So we all
And
need to invest in Turkish toilets. That's what you're
yeah,
saying. Yeah,
exactly. So Turkish
right.
toilets are perfect for for
Yeah,
for stool. And if you still have the regular toilet, it's fine. But then find something like a small stool or something, or put something under your feet to have that position of your knees, and that
right.
opens your rectum fully, and that's much easier to produce stool. Yeah.
That's a fantastic advice actually that I think most. I mean, like when you say it now, it's just so it's just common sense, but I don't think anybody really thinks about it.
No.
It's so that was really 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 great advice. The last thing here, Zlatan, thank you so much for your time. So your last, if you would give like any endoscopist, like a junior endoscopist, who's sitting and looking at referrals that are popping in, if you give them like the t top three advices for how they should deal with uh, this type of referrals, what would you say, like in short?
Yeah, well, the first thing is know the alarm symptoms, so understand, how to triage your patients. And if there are no alarm symptoms, take the time to just understand what the symptoms are that your patient has, and educate them. So take time for patient education. And it's not because we have endoscopy that we always should use endoscopy. It's an invasive procedure, and it shouldn't, and costly, etc. It shouldn't be done without good medical reason. So sometimes it's the easier way for us, but investing 5 or 10 minutes more into a good talk to your patient helps the patient much more than just another upper GI endoscopy. Yeah.
Wonderful, wonderful. All right, great. Dr. Zlatan, that was really, really helpful. I certainly learned a lot, and thank you so much for your time. And hopefully, we will have another chat where we maybe delve into something else that is to your liking, other than just functional bowel disorders. Anything else you would like to add before we wrap up?
No, I think we talked about a lot. Happy to be here today. Thank you for the invitation once again, and I'm looking forward to the next episodes with colleagues.
Perfect. Thank you so much, Zlatan. Have a great day and see you again soon.
All right, all the best.
Bye bye.